Good afternoon, everyone. Good afternoon. My name is Dr. Christopher Ervin, and I will be the Master of Ceremonies for today's awards luncheon. And my background is emergency medicine, and usually, like in the emergency department, you think everything is going to go well, but you find yourself having to think on your feet very quickly. And given the many important speakers and panelists we've had to make some adjustments to our schedule on the fly. And so once again, I would like to say welcome to the National Leadership Summit in Spring Health Braintrust. And I hope you have been informed and enlightened by this morning's speakers. And so we will now continue with the schedule. And even though this is part of the Booker T. Washington Awards Luncheon, we would like to start off by introducing Congresswoman Allyson Schwartz, who I could say many, many wonderful things, but due to time constraints, I have to limit myself. She's the president and CEO of Better Medicare Alliance. She's also the former member of the House of Representatives for the state of Pennsylvania from 2005 and 2015. One of the most notable achievements is she was the driving force behind Pennsylvania's CHIP program, and that served as the model for our federal CHIP program that now continues to serve many of our youth today. I would like to welcome to the stage Congresswoman Allyson Schwartz.
Okay, good afternoon. We were just saying last year I spoke just before lunch, and they always makes you a little anxious because people are hungry. So good to see people eating this year, and glad to be back. And by all means, keep eating, and we'll keep talking. So I'm very pleased to be with you again this year, and I certainly want to acknowledge Gary Puckrine and the great work that he does, not only for the National Minority Equality Forum, but as a member of the board of one of our allies, it is, for a Better Medicare Alliance. And he was one of the original founders of Better Medicare Alliance. So I want to thank Gary for his leadership role, both here and, of course, with us as well. And he's been a good friend and advisor as I began as the first president and CEO just 2 years ago with Better Medicare Alliance. So congratulations to the National Minority Equality Forum. Again, really pleased to be here. So I'm going to talk about for just a few minutes this morning, as your program gets going, is really what's going on here in healthcare in Washington. I'm sure that's going to be very much a part of the conversation. But as you know, since the beginning of this congressional session, almost 100 days into the new administration, we have all been watching the new and sharply partisan fight over healthcare in Congress and in the nation. 7 years after the ACA, 50 years after Medicare, and we continue to see deep divisions over how to handle health care for our nation. So what can we expect? What comes next? Well, I had different notes from last week, but given the news from last week, it looks like we are going to see a second effort, a continuing effort, to repeal and replace the ACA. We expect changes. They're still being discussed. We know what the last repeal and replace that didn't get voted on looks like. There's still conversations about what that might look like and whether they're, in fact, the necessary votes in hand to do it. And no matter what the conversation is around the ACA, repeal and replace, and I think we all have strong feelings about it one way or another. I was in Congress during the ACA and on the Ways and Means Committee, so I am well aware of what it took to get the ACA done. It is, I'll say on a personal level, really a major achievement that I'm very, very proud of. So I watch this with personal interest and interest for the nation. But what I do also see is that whatever those conversations are, at least two issues that continue to come to the fore around healthcare and healthcare reform, and that need our attention even post-ACA or continuing ACA, however it goes. And that is, one, the cost of healthcare for patients and their families, and the healthcare system and the cost of the healthcare system. And second, the importance of improving healthcare and health outcomes for high-risk patients, many of whom come from underserved communities. So despite the political arguments around the ACA and whether we replace it or not, whether we still have to find answers to these very real challenges. In Congress, I served on the Ways and Means Committee and the Budget Committee. I experienced firsthand the debates within the party and across the aisle on how we could finance affordable, quality health coverage for all Americans. The issues are not easy, and the perspectives are divisive, and the goals are not all aligned. But finding solutions are hard. Now, I'm the head of a diverse coalition of more than 80 key stakeholders in healthcare, national, state, and local organizations responsible for the coverage and care of millions of patient lives. And I continue to see and engage in bringing these diverse perspectives from inside and outside the Beltway to answer these important questions. So pundits will continue to dissect the efforts of policymakers to find the answers and explain the discourse, often, as you know, because you're here in Washington, measured by political fights and the messiness of lawmaking in Washington. But what should not get lost in this conversation is the critical questions that must be answered. How do we improve our healthcare system for all, no matter race, gender, or where a person lives? In the midst of the swirling debates, the question is, how can we achieve better outcomes at a lower cost for all of us? And the need to answer these questions could not be more urgent. As you know, America is entering a time of unprecedented senior population growth. Meeting the challenges of a population that is going to almost double in the next decade is really a challenge for all of us. Just a few numbers. There are over 10,000 new seniors every day in this country. Over the next 25 years, the number of Americans over 65 will more than double as the baby boomers age. And will grow from almost 40 million in 2010, people over 65, to 88 million people over 65 by 2050. Our aging population is also becoming more racially and ethnically diverse, with racial and ethnic minority in populations increasing from 6.3 million in 2003 to 9.5 million in 2013, and projected to be 21.1 million by 2030. So despite reforms enabled by the ACA, racial and ethnic seniors are still experiencing a disproportionate burden of chronic disease, of death, and disability, even as they have the same insurance and socioeconomic status as their non-minority counterparts. This is facts you know, I'm sure. The fact is that few of us who do not know someone who's concerned about the cost of coverage, who's concerned about a pre-existing condition, or is living with a serious chronic condition, or is up against a whole lot just because of where they live. Half of American adults have at least one chronic medical condition. 86% of what we spend on healthcare is linked to these chronically ill patients. And 85% of seniors have at least one chronic disease. Half have multiple chronic conditions, and 14% have 6 or more chronic conditions. I always joke with seniors when I'm talking to them when I was a member of Congress, do any of you take a prescription drug medication? They would all laugh. I'd ask if they took one, ask if they took 2 or 3. They'd still laugh, ask if they took 4 or 5, and hands would go up. And lots of people took 6, 8, 10 medications to treat their chronic conditions. Not at all unusual for seniors today. 10% of Medicare beneficiaries account for 75% of the costs. That's a stunning number. Every time I read it, I think, how can that be? But it's true. These are high risk, high need, and high cost individuals. And their numbers are growing, and they're living longer with these chronic conditions. And the system they face, and in fact most Americans face, is one that's fragmented and narrow in focus. It's based on fee-for-service payments designed for short episodes of acute illness and expensive hospitalizations, not for chronic conditions that require long-term management. So in many ways, in too many ways, fee-for-service healthcare system is failing us. So while there's lots to be proud of in American healthcare, we must be smarter in the way that we finance and deliver care to shape the future of healthcare in this country. The alternative to outdated fee-for-service model of care is innovative public-private partnerships in Medicare Advantage, the program that we advocate for within Medicare, Better Medicare Alliance. It's a program that has been around for 30 years, and it has grown significantly in just the last 8. Medicare Advantage provides seniors with a choice of obtaining Medicare benefits from a private plan, and it is now an option that's available to 99% of Medicare beneficiaries. It's a capitated system of financing that shifts the responsibility, or shares the responsibility, I should say, for cost and care with plans and providers. It relies on adequate payment, accurate risk adjustment, and beneficiary engagement. And it changes the incentives in healthcare. It changes the focus of care to patient-centered, integrated care, and early intervention, care management, particularly for those with chronic conditions. And the results are improved outcomes for millions of beneficiaries. At BMA, we're especially encouraged by recent findings from CMS showing improvement in care delivered for minority beneficiaries enrolled in Medicare Advantage. While the data analysis indicates the need for improvements across our healthcare system, in Medicare Advantage and Medicare, and certainly for those under 65. In some cases, minority beneficiaries enrolled in Medicare Advantage are showing areas where there are reduced gaps in care delivery and outcomes, reduced disparities, something we should be proud of and want to build on. According to the report, Asian Pacific Islanders show similar or better outcomes across at least 19 clinical care measurements, African Americans across 13 measurements, and Hispanic at least 15 quality measurements. Regarding patient experience measures, it's significant that African American and Hispanics report similar or better experiences in at least 5 measures. This year is the first year that CMS also released gender differences in patient experience and clinical outcomes among Medicare Advantage beneficiaries. And in 8 patient measurements, women and men get similar care, including getting needed prescription drugs and important care coordination. In 24 measurements, they do the same or better, and 16 measurements were rated as similar for both sexes. 5 showed women got better care than men, and 3 showed that men got better care than women. So we have a ways to go with all of these measurements and how we're doing. But we start with the assessment. I'm very pleased that we've worked closely with Dr. James on the work she's doing, and encouraged her to report these findings and to hold us accountable for doing better on disparities. In other reports, evidence around Medicare Advantage shows that access to primary care increases the rate of preventive health visits by 20% for some of the most vulnerable seniors. It increases necessary health screenings, reduces ER visits, and lowers avoidable hospitalizations by 10% across the country. So there may be a number of reasons for this, but we see the progress, and I will say from the experience of our allies who talk with us about their experiences, there are several key factors that have enabled this improvement and this kind of difference that we're so proud of. Reducing hospitalizations, improving prevention, early interventions, all critically important to people, particularly for those chronic conditions, and diagnosing them early. So first is the decision to meet quality measurements and improving outcomes. That is incentivized under Medicare Advantage in a way that it's not in fee-for-service. There are reports and a star ratings program so that you can look at your Medicare Advantage plan and see whether it's actually getting the kind of star ratings program that you would want to, whether they can get to a 4 or 5 star rating the highest. Second is building on evidence what works. Care coordination, particularly for those with serious multiple conditions, having a primary care provider, and ongoing relationships with care providers. Teamwork and identifying who is your provider, where do I go, how do I get my care. Understanding and addressing social determinants that affect health status is key to improving outcomes and reducing costs for high-risk, high-need beneficiaries. Attention to smoothing, that's not bad either, but smoothing the transitions of care makes a keen difference as well. The experience shows that providing care in the home, particularly post-hospitalization, reduces readmissions saves dollars, and improves health. And identification of high-need, high-risk patients using risk stratification data and primary care teams and care management strategies reduce hospital stays and also improve outcomes. And last is in innovations in service delivery, from home as a site of care to telemedicine and flexibility and benefits, all being used in Medicare Advantage today. So we believe that community partnerships under Medicare Advantage, some of our allies are the YMCA and Meals on Wheels and area agencies on aging, all providing care right where the patient is, engaging patients, and offering social supports that enhance the opportunity for healthier outcomes. So we are working to lead on this, to be able to use a capitated system, to be able to provide this broad range of health care, and really not just medical care, but health care as well. So uncertainty as we move ahead means that we're going to continue to advocate for Medicare Advantage, and we're going to continue to advocate for no matter what happens in Congress this week or next week or the weeks ahead, that we do not walk away from what we learned as working in healthcare today, that we can achieve better care at the same cost. We can learn from the positive changes that we've seen implemented over the last 10 years, and that we should be sure that we do everything we can to ensure that the financing and delivery of care meets the needs of patients over 65. I know many of us care about people under. But what we do in Medicare has a huge impact on healthcare in this country. You know that, as many of you are providers and who work in the space, you know that what you do under Medicare, the kind of financing that is run by Medicare makes a huge difference for the care that you provide for all patients. If we can also be a part of this really important effort to reduce health disparities in healthcare, that is one that I would be very proud of as well. So I want to recognize the leadership again of Gary Puckrein and the National Minority Quality Forum in building a platform that has helped drive attention and action on the issue of health disparities. Been with Gary when he's talked about diabetes and how important it is for us to intervene early to make sure that people with early stage diabetes do not get to end-stage diabetes and renal dialysis and some of the terrible things that happen once we go that route. Slow the disease progression, prevent it from getting worse, and engaging policymakers and payers and providers to engage in the best practices of early intervention, slowing disease progression, care coordination, and attention to people with multiple chronic conditions. That's what's going to save us money the right way. It's going to build a healthcare system that works for all Americans, and we're going to do that by working together. So thank you for the work that all of you do. Thank you for including me in this forum, and look forward to working together to tackle the real challenges ahead, getting better healthcare at a better cost for all Americans. Thank you.
Thank you, Congresswoman Schwartz. With your career beginning with our youth and now through BMA, you're working with our seniors. You truly are covering the lifespan of healthcare. Now, welcome to the stage Tomás León, who will be of the President and CEO of the American Hospital Association's Institute of Diversity, and he will be introducing the recipient of this year's Booker T. Washington Award.
Good afternoon. Oh, that sounds beautiful. All right. I bring greetings to you from the American Hospital Association's President and CEO, Rick Pollack. I also wanted to congratulate and acknowledge AHA's Chief Medical Officer and President of Health Research and Education Trust, Dr. Jay Bott. He's en route. I know we'll be honoring 40 under 40 leaders, but I wanted to congratulate him on being named one of the 40 under 40 leaders in minority health. I would like to thank Gary. Gary, I appreciate your leadership and your partnership and all of those that are part of your team at the National Minority Quality Forum for just the opportunity to be here and lock arms with you, lean into this work of eliminating disparities, but moving towards creating sustainable, healthy communities and the opportunity to present this year's prestigious Booker T. Washington Award. As you know, this year's award is being presented to John Bluford. John is a true ambassador and tireless advocate for advancing health equity, eliminating disparities, and promoting diversity in healthcare leadership. He is a special friend to AHA and the Institute. John is the former chairman of the AHA Board of Trustees and a highly regarded healthcare innovator and leader in the healthcare field. He was instrumental in starting the national call to action to eliminate healthcare disparities, of which AHA was a founder of, that led to the creation of AHA's hashtag 123 for equity. So if you're using social media today, add hashtag 123 for equity to that. This is a campaign to eliminate healthcare disparities, and to date we have 1,500 hospitals and health systems that have taken the pledge to take action. So, John, thanks for kicking that off and being part of making that happen. He's a person that puts his talent and his passion into action. When I was mentioning all the wonderful things we were going to say about him at the table, he says, hey, it's not about me, it's all about the students. And that's the type of person that John is. I also learned he's a standout point guard in basketball. So, all right. I'm going to see your moves when you come up here, John. You can see some of the example of his legacy work in action through an organization he founded, the Bluford Healthcare Leadership Institute. The purpose of the program is to develop the next generation of culturally sensitive leaders with the ultimate goal of eliminating disparities in healthcare. Over his 40-year career, John has inspired and mentored and developed exceptional scholars to become the next generation of healthcare leaders that will truly help build sustainable organizations and sustainable healthy communities. His life work truly embodies the essence of the Booker T. Washington Award. My friends, please join me in congratulating and welcoming to the stage Mr. John Bluford.
Thank you, Tomás, and the American Hospital Association and the Minority Equality Forum for having me here. This is my second tour of duty, Gary. I was here several years ago on behalf of Truman Medical Centers for a number of programs that we were recognized for, like education in hospitals and hospital and an art museum, introducing art to urban core safety net hospitals to bring joy to those patient populations and so forth. But I'm very pleased to be here today on behalf of the Bluford Healthcare Leadership Institute. It has a dual purpose. The first and foremost is to create a pipeline of minority talent, principally from HBCUs, historically black colleges and universities, namely Fisk University, Morehouse University, Spelman College, North Carolina A&T College, and Florida A&M University. We bring these very talented students to Kansas City, Missouri, for a very intense, almost 24/7, 2-week experience that is both didactic and experiential. And in those sessions, they are introduced to notable members of the healthcare field, from the Kevin Loftons of the world that run multi-billion-dollar hospital systems, to the Rick Pollocks of the world who run multi-hundred-million-dollar associations, to CEOs from Walgreens and other industries, to Cerner and healthcare electronics, to Kathleen Sebelius, who gave an excellent talk about her life and later what she did with the Accountable Care Act. And the point is that all of our faculty members and speakers talk about their personal experiences and how they got to where they are. And the point is, for these young, bright minds, they're undergraduate students, by the way, The theme is, if you can see it, you can be it. So our idea is to take talented young people with leadership potential and instruct and inform and educate them on healthcare-related issues in the hopes that they will enter the field. Our intent is to equip them with management skills, leadership skills, and executive presence, which is very important because the intent is to provide them with the tools to affect change in minority and vulnerable patient populations. Our success measurability, in my view, will be in reducing inequities and healthcare disparities to zero over the next 2 generations. In my view, that would be my 4-year-old grandson's children. That's the goal. And we hope to do that by placing these exceptional scholars in critical decision-making positions in the field. And we will do that over the next, we've been in business for 5 years now. We hope to do that over the next 10 to 15 years. And then within 15 and 20 years, we will be seeing a significant difference because of their presence and their passion and purpose in working with vulnerable patient populations. I am very pleased to be here to accept this acknowledgement and recognition. Thank you. And for those of you who are interested in knowing more about what we do and perhaps interested in participating in it, please go to our website, blufordinstitute.org. Thank you very much for this recognition.
Again, thank you, Dr. Puckrin, Tomás, León, and John Bluford are this year's recipient of the Booker T. Washington Award. As we can see, your commitment to a diverse and healthier community is unquestionable. And of course, this award is just a simple demonstration of your work. Now we must continue with our program, as I said, being quite flexible and bendable. We now will start calling up our distinguished panel as they make their way to the stage for brief remarks. I must say in advance that the brevity of the introduction is in no way a reflection of the depth of their achievements achieved by our panelists. We have already had Congresswoman Schwartz present. Now we'll have come up to the stage Isabela Niculae, Associate Director of Global Recruitment and Retention Strategist and Women in Innovation, the United Kingdom chapter of Biogen. Ms. Niculae has more than 15 years of clinical research experience in neurology, oncology, and ophthalmology. Her role at Biogen is to develop long-range patient centricity strategy, a little tongue twister, and contribute to strategic input for patient engagement and patient investigator advisory boards to advance recruitment and retention cross-culturally. Welcome, Ms. Isabela Niculae, if she's here. There we go. Next we have Ms. Myisha Gatson, Senior Director for Advocacy and Strategic Alliances for Pharmaceutical Research and Manufacturers of America, PhRMA. In her role, she brings 15 years of expertise in health policy and public affairs, building collaborative partnerships, and coordinating outreach to multicultural and LGBT communities. Welcome, Ms. Myisha Gatson, excuse me. Now to introduce Dr. Barbara Hutchinson, President of the Association of Black Cardiologists and a Fellow of the American College of Cardiology. Along with leading ABC, she is the Managing Partner of Chesapeake Cardiac Care, located in Annapolis, Maryland. Besides being her work, she's a noted speaker for heart disease in women and how sleep affects heart health. Dr. Barbara Hutchinson. Finally, Dr. William McDade, who will come with us to share AMA's strategic initiatives and the organization's plan for achieving health equity. Dr. McDade is a board-certified anesthesiologist and was elected to the American Medical Association Board of Trustees in June 2016. Currently, he serves as the Executive Vice President and Chief Academic Officer for the Ochsner Healthcare System in New Orleans. Dr. McDade. Now, our panelists will come and speak in the order of introduction.
Hello, everyone. Thank you so much for the opportunity to speak here today. I'm very humbled to be in front of you and discuss one of the topics that's very passionate to my heart, and that is clinical research. As mentioned, I've been doing clinical research for about 20 years, and in hindsight, there's been a lot of changes, but we have a long journey ahead of us, especially in addressing disparities within clinical trials. One of the items I wanted to discuss with you, I don't see any slides, but I guess that's okay. I don't think it comes as any surprise that the minority groups are underrepresented in clinical research. I just want to state some statistics for you. Even though African Americans make up 12% of the population, only 5% participate in clinical research. Similarly, with Hispanic populations, 16% of Hispanics make up the U.S. Group. However, only 1% choose to participate in clinical research. That's similar to women. In typical studies, for example, in cardiovascular, 76% of males participate, a much smaller fraction of females. And if you move away from the private sector, let's say the NIH, we see similar findings there, where less than 5% of research conducted in respiratory area is funded and has appropriate racial and ethnic diversity. So as you can see, there's quite a large gap there that needs to be addressed. So we have a long road ahead of us, but I believe we're starting to move in that right direction. We're seeing a lot of movement in terms of some of the top agencies today, especially the FDA. The FDA called the year of 2016 the year of clinical research diversity. I think in the 20 years I've been doing this, it's been the first time I've seen the FDA really take a step forward in trying to address this. We see similar things happening in the NIH, where funding for minority research engagement is being put forward, and the same with the NMQF, and a lot of other things going on in terms of legislation. So we are certainly moving in that right direction, but again, we have a long way to go. And not only do we need to look for the FDA and other large bodies to help us along in our journey, we must be active participants. So I want to talk to you a little bit about the initiatives that we are taking a part of within Biogen, and just a few. And I have to sort of provide you with a preamble. We're very much in the early stages of this journey, so we have a long ways to go. Some of the things that we've been engaging in is bringing the patient to the forefront. You know, we talk about patient centricity, but we really need to be an active and mindful participant of making that happen. And one of the things that we've been doing before we design that roadmap, the protocol, as we call it, we really bring in the patient. And we sit around the table with specific patients, with advocacies, and we ask them. We ask them about their fears, about their concerns. And in return, we actually teach them about clinical research and what we do. It's amazing to hear some of the stories from these individuals. There is a lot of lack of or misinformation out there regarding clinical research. So I think we all have a responsibility to teach individuals, to teach minority groups about the importance of clinical research. One of the activities that we are currently taking a part in is designing a patient-friendly clinical research brochure. I know that sounds quite simple, but often the key message that we get in these ad boards that we participate in is this fear of the unknown. And to many, clinical research, clinical trial is that big unknown. There's been incidents in the past where there still remains a lot of fears. So we really need to demystify what it means to be a part of clinical research, because without clinical research, as many have spoken here today, we won't be able to develop the right medications for the right patient. The other piece that we are currently involved in, and we're hoping to advance, is we're creating a pilot with a community called HEAL. It's the Health Education and Learning, part of the ARCH establishment, where we are going out to large congregations, for example, large African American churches in Atlanta, Georgia, or Los Angeles in the Hispanic population, and we teach them about diseases, we inform them about what we're doing, and hopefully through that sort of communication, through that exchange, we are introducing more information to individuals to make better and more informed decision about their health. And again, I think we have a long ways to go, but together we really can make a change in addressing disparities in clinical research. I'll stop there. Thank you very much.
Good afternoon. It's my distinct pleasure, and apologies for my voice, it's a little hoarse today, allergies. It's my distinct pleasure to be here at the NMQF National Leadership Summit on Health Disparities in Spring Health Braintrust today. I bring you greetings on behalf of Stephen J. Ubel, President and CEO of Pharma. NMQF has been an important partner to Pharma, and we look forward to continuing to grow and build the partnership in the months and years to come. I was invited here today by Gary to introduce myself as one of the newest members of the Pharma Alliance team. As the Senior Director of Advocacy and Strategic Alliances at Pharma, specifically I manage the multicultural and LGBT alliance building activities on behalf of the organization, in addition to being the team lead on a number of policy issues. So as I thought about what I'd say here today, I was at a conference this weekend and I heard this quote that really spoke to and I think embodied the way that I seek to do this work at Pharma. The quote goes, "Diversity is a fact. Inclusion is an essential practice, and equity is a fundamental goal." So when you think about diversity as a fact, in 2015, we saw the first group of infants born in this country where there were minority births surpass the births of white infants. It's no longer a data point that's so far off in the future that we can't see that minorities are going to be the emerging market, in the words of Gary Puckrin. When you talk about essential practice, I think of that as something you do in alignment with the goal. If the goal is ultimately equity, I see my work as a part of that essential practice. Thinking about every day, how do we leverage the resources of Pharma and develop partnerships to move the equity conversation further along. And that's why we're partnering with groups like the National Minority Equality Forum, NAACP, the National Urban League, the National Black Nurses Association, among many others. So we all know the unfortunate reality that racial and ethnic minorities are over-indexed in almost every chronic condition you can think of. And at Pharma, one of our fundamental goals is to work to make sure that patients get the medicines that enable them to live longer, healthier, and more productive lives. And a critical part of building sustainable, healthy communities is ensuring access to innovative therapies and cures. So we look forward to continuing our work with you and working with many of the organizations represented in this room who labor daily to remove barriers, reduce disparities, and ultimately work towards achieving equity. Thank you.
Thank you. As the president of the Association of Black Cardiologists, it's indeed a pleasure to be here today, and I would like to share with you over the next few minutes a different aspect of disparity, and it's around the whole issue of access, and share with you some of the things that we are doing in the association to minimize, or to improve, I should say, the healthcare access for minority and other high-risk populations. And I have the slide set is up. There we go. The question is, why the whole issue of access? Why are we interested in this? Well, there are a lot of advanced therapies offered now for the treatment, as treatment options for patients that are at risk for cardiovascular disease. And still, many of these patients are unable to get these medications. And so, this paper was published back in August, and it addressed the issue of the trends, what trends we see in terms of mortality rates in cardiovascular disease, heart disease, stroke, and cancer. And interestingly, as shown on this slide, we see that for or for whites on the left, there is still a gap in terms of heart disease, stroke, when you compare it to cancer on the bottom. But off to the right, as we look at African Americans, or I should say blacks and other minority groups, we see there is still a big gap in terms of cancer, and heart disease is still prominent among African Americans. When we look at some of the new therapies that are available in the field of cardiovascular disease, we have the NOACs, or the new oral anticoagulants. We have the angiotensin receptor neprilysin inhibitors, and we also have the PCSK9. And we polled cardiologists to see how often or how are they able to get these medications for their patients. And if you look at the slide, you'll see off to the right that for the PCSK9, almost 64% said that these prescriptions were either delayed or denied for these patients. Similarly, the angiotensin receptor neprilysin inhibitors, as well as the NOACs, that was about 44%. So although these medications are known to improve, they're still not accessible. So one of the goals or the objective of the association was to convene cardiovascular opinion leaders and advocacy experts, and to address this whole issue of access. And the goal specifically was, one, to look at some of the barriers to access, and more important, come up with solutions that we could take going forward. And we were able to bring together patient advocate groups, physicians, policymakers, as well as the payers at a round table that was held in New Orleans. And coming out of this round table, we were able to identify the top barriers to access. And some of these included the cost of the drug to the patients, obviously, but also we talked about the suboptimal access to primary care. There was still a number of primary care physicians that were not taking Medicare or medical assistant patients. There was also the thought that there was a low referral to specialists, so many of the primary care physicians were still taking care of some of the chronic disease patients that may have been a little more difficult. There were also the social economic determinants of health that we can't seem to get away from. And there was also lack of cultural competent providers taking care of underrepresented group, minorities, that just didn't seem to understand the culture. And there was a limited access to generic medications. We thought this was another barrier. And finally, like I stated earlier, refusal to accept certain insurance. Certain physicians, they did not accept certain insurances. So we came up with several solutions. As shown here, one off to the left is having telemedicine to address some of the access issues. We also thought of standardizing the authorization process because many of us thought it was long and tedious, and after 4 tries, you're still told no, or you still deny the drug. And very often people had to have increased pay, workers in their offices to even manage the whole authorization process. Then we also thought we need to advocate for policies for acceptance, more physicians to accept both Medicare and Medicaid. Another big solution we thought would be pharmacy programs to help improve access to care. And finally, expand the whole concept of healthcare workers such that you can have healthcare workers that are available to expedite processes in the office. So these were some of the solutions. Subsequent to that first meeting in New Orleans, we had a follow-up meeting, and what we did is we chose 2 of these solutions that we'd be working on in 2017. And the 2 programs here would be the pharmacy program and standardizing the whole authorization process such that it is not long and tedious. So after all of this, we hope to be able to submit our recommendations to the healthcare community at large so that we would all, going forward, have not only recognized the barriers, but also some of the solutions that can help improve access to important medications. Thank you.
Well, thank you, Dr. Puckrin and Dr. Ervin. I bring you greetings from the American Medical Association. The AMA has partnered with NQF for the full 14-year history of the Leadership Summit, and we are pleased to work with the NMQF and the Congressional Black Caucus Health Braintrust as summit partners. We commend Dr. Gary Puckrin for his sustained vision and leadership in promoting NMQF activities. The AMA has had physician representation at the summit since the beginning, and I'm joined at the summit by a number of those individuals who I believe Willarda Edwards may be with us, but she'll be here later on, who also serves with me as a member of the AMA Board of Trustees. We've been actually at a number of summits and agree that one of the most important meetings of the year is right here. The chair of the AMA Minority Affairs Section Governing Council, Dr. Frank Clark, is also with us today, as are members from the section. The Minority Affairs Section Governing Council is composed of representation from the NHMA, the AAIP, and the NMA as well. And Dr. Westcott and Dr. Mitchell from the NMA are in attendance with us today. This summer, the MAS will submit 6 resolutions to the AMA House of Delegates for consideration, dealing with issues from educating a diverse workforce to health care as a human right. The Minority Affairs Section has also created the Doctors Back to School program. And we are partnering with Mentoring in Medicine to hold an event this Wednesday on 26th of April at the Charles Flowers High School in Prince George's County, Maryland. We invite you all to join us as we speak to the 200 African American science and technology students there about careers in healthcare. Anyone at the AMA table in the foyer will be able to add you to our list of individuals if you're interested in participating with us to lead a small group discussion on Wednesday. The AMA has also launched Strategic Health Foci, designed to create change in medicine. Accelerating change in medical education is the next generation flexenarian approach to improving medical education. A focus of the ACE initiative deals with health equity and how we can align the curriculum of the medical school of the future to eliminate health disparities. Another strategic focus area aims to reduce morbidity and mortality due to hypertension and diabetes, 2 diseases that disproportionately impact minority communities. And we are making significant strides there too. The AMA Foundation continues to grant the Minority Scholars Awards to underrepresented minority students of achievement and need. These scholarships are valued at $10,000 each. And this year, the Foundation, in concert with ABC, will award the Dr. Richard Allen Williams and Janita Evangelista Johnson Scholarship as part of their 25 awards. The Foundation also awards grants to free clinics that provide diabetes management and prevention services to those who can't afford it. So I have a short video that I ask you to view with me that describes a few of the AMA's efforts that align with our mission of achieving health equity and welcoming all physicians to membership. Please roll the video.
It's your mission to help people live their best lives. It's what physicians do. One of the ways the American Medical Association supports your mission is by helping physicians and patients achieve health equity. At the AMA, we believe all Americans should have access to affordable and meaningful health care. The AMA is attacking this issue systemically through our advocacy efforts to make health care more accessible to everyone, and through our 3 strategic initiatives. Here's a look at how we're addressing these challenges to ensure a healthier tomorrow for more Americans.
As the Director of Clinical Community Linkages, it's my role to work with physicians and care teams across the country by linking them to evidence-based chronic disease prevention programs in the community where most health is affected. And so one of the ways that we're doing that is we've developed a toolkit that helps ambulatory care settings to collect patient-level data on race, ethnicity, and preferred language to determine if there are differences in care and outcomes. And once those are surfaced, we help them to mitigate those differences wherever care is accessed. And this includes federally qualified health centers, as well as free and charitable clinics.
Within the AMA ACE consortium of 32 schools, we've got groups that are working deeply in this area and developing new curricular experiences and new experiences in communities. But equally important is addressing diversity in our healthcare workforce. And some of our schools are doing deep work on changing admissions and pipeline programs to be sure that we really get the diverse workforce that we need for future healthcare. It's important that young physicians in training understand that only about 20% of our health overall is affected by the healthcare system. And the biggest component really comes from the social determinants of health.
Health equity is every physician's job. And our job at the AMA is to help physicians do what they want to do what they were trained to do, which is caring for patients. If we're really going to care for all patients across the United States, all the diversity of patients, we need an engaged physician workforce. Our resources like Steps Forward and our burnout assessment tools allow physicians to assess their practices and find ways that they can leverage their entire care team to care for their patients.
The AMA has myriad policies around the areas of health disparities and health equity, from ensuring that the Public Health Prevention Fund continues to be funded, from areas of juvenile justice and understanding and appreciating the school to jail to prison pipeline, which disproportionately impacts use of color. As well as understanding health issues, chronic conditions like diabetes and high blood pressure, which disproportionately impact minorities. So we believe that patients and the public are our partners in this, and our website, Patients Before Politics, is a wonderful way for patients and the public to get engaged. Because at the end of the day, if we all step back and step away from the rhetoric, and get to the core of, again, why we're here, it's about the patient.
You're driven to help your patients live longer and healthier. And the AMA's effort to achieve health equity supports you in this goal by working collaboratively with organizations to improve access to meaningful care for everyone.
In that video, you got to see Chris Holliday, who's actually here. The final person who spoke, aside from Jim Madera, was Patrice Harris, who's now the chair of the Board of Trustees. She's the first African-American woman chair of the Board of Trustees of the American Medical Association. There are actually 4 African-Americans on the Board of Trustees of the American Medical Association today. The AMA is known for its advocacy efforts and leadership in medical education, but it's making important strides in improving the lives of patients and the doctors who care for them. Using technology, AMA is innovating to make practices of physicians more efficient and effective with the goal to give each physician back an hour of their day. So, thank you for the work that you do in NMQF and your continued motivation to end health disparities and to promote health equity. The AMA is, again, unprecedented leadership that's focused on areas that impact communities of all America. We hope that you join us on this mission, and we have a table with representatives in the foyer if you'd like to join us in this quest. Thank you.
In Atlanta, I am part of a group that is working on improving the healthcare in the South Metro region. And part of 2017, we adopted a hashtag Stop Admiring the Problem. And so for all the work we do from 2017 going forward, we appended hashtag Stop Admiring the Problem to the work that we do. With our award recipient, John Bluford, BMA, Pharma, Biogen UK, ABC, and AMA, and of course, Dr. Gary Puckrin and NMQF, we are seeing that we're reaching an era where we have many people regarding health equity, improving health care amongst diverse communities, that we're now getting to a point where we're now stop admiring the problem. And so I thank all our panelists, our lunch attendees, as much as I would love for questions to be taken from the audience, to keep in respect to our schedule and to allow our next sessions to go forward. I request that you have any questions for our panelists to ask them outside the room. Again, thank you. Thank you.